I'd like to just start by thanking Dr. Bremner, Dr. Shute, and Dr. McGuff for 3 really great presentations, and I think they're going to help us set the stage to get going with the rest of this afternoon's program. I just have a couple of remarks before we lead into the next section. Yesterday, I heard an OBGYN from Louisiana talking about how they've implemented some of the work around early elective deliveries. And of course, one of the things they did was put in a hard stop around the scheduling process. And it requires that the doc who's trying to schedule a patient for early elective delivery actually has to give the reason. And her favorite reason that she likes to share with people is that the patient wanted to be able to fit into her wedding dress by a certain time. So that one sort of takes the cake. Also, I just wanted to add to Pete's remarks about measurement. The Alliance is currently developing the ability to measure 10 of the Choosing Wisely recommendations using measure specifications that have been developed by Premera. Premera is gracious enough to share those specifications with us, and we are hoping to have some results by the end of this year that we'll be sharing that have both statewide and county level results on 10 of the metrics. Premera is currently in the midst of developing specifications around another 10, and when those 10 are available, the Alliance will be working with those as well. This afternoon, then, this next section, we actually have 3 presentations that will provide brief overviews of what's happening locally around implementing Choosing Wisely. Our first presenter is Scott Ramsey, who actually was regrettably not able to attend in person today, but he has kindly recorded his presentation, which we're going to watch on the screen in just a moment. I think many of you know Dr. Ramsey. He's an internist and health economist with the Cancer Prevention Program at the Hutch, where he focuses on clinical and economic evaluations of new and existing cancer prevention, screening, and treatment technology. Following Dr. Ramsey will be Diana Buist. Diana Buist is an epidemiologist and health services researcher at Group Health, and we heard from her through a few comments earlier. She's currently leading a grant with Dr. Matt Hanley to reduce low-value care. This project includes operationalizing Choosing Wisely materials within the group health delivery system, so that'll be really interesting. And then finally, we're going to hear from Dr. Scott Kronlund and Dr. Francis Mercado, Dr. Kronlund is a board-certified family physician and is currently the chief medical officer with Northwest Physicians Network, which is a 500-doc multi-specialty IPA in Pierce and King County. And Dr. Mercado is a general internist and also the chief medical officer for Rainier Health, which is a new CMS-recognized accountable care organization founded by NPN, Scott's organization, and the Franciscan Health System. This segment of the agenda is going to be about 45 minutes long, so it's kind of a rapid fire, and I'm going to ask you to hold your questions for all of the speakers until the very end, so we get through all 3. We'll take a few questions at the end, and then we will move into our tabletop discussions. I also just wanted to, a couple of new people snuck in. Welcome, you got here just in time for dessert, so your timing is excellent. And I also wanted to welcome Carol Ostrom, who's with the Seattle Times, and we're delighted that you're here. We'd love to get some more information out in the popular press about Choosing Wisely, and so thanks so much for being here.
Hi, I'm Scott Ramsey. I'm the director of the Hutchinson Institute for Cancer Outcomes Research. I'm a member in public health sciences at the Fred Hutchinson Cancer Research Center. I'm also a professor in the Department of Medicine at the School of Medicine of the University of Washington. Today I'll be talking about a project that our group has been implementing to address the Choosing Wisely interventions for cancer. Briefly about our institute, the Hutchinson Institute for Cancer Outcomes Research has been founded at the Hutchinson this year with a mission to improve the effectiveness of cancer prevention, early detection, and treatment services provided to patients in a way that reduced the economic and human burden of cancer. The Institute in some ways has been formed with the realization that cancer itself is becoming so expensive that it is actually a threat to patients' access. So we're engaging in several projects that are focused on reducing the cost of cancer and the burden of cancer to patients. Several of you probably know about the Choosing Wisely initiative. It's a joint venture of the American Board of Internal Medicine and many specialty societies, including the ASCO, the American Society for Clinical Oncology. And what I have listed here are the 5 recommendations from ASCO as part of the Choosing Wisely program. We engaged with several area oncology providers on the subject of implementing the Choosing Wisely recommendations, because even though these recommendations are out there and hope to be followed, there is no plan for implementing them. So we have taken that task with some community collaborators. We initiated this via a teleconference about a year ago, where we presented the concept of a community-driven approach to implementing the ASCO Choosing Wisely recommendations. At that call, I acknowledged the importance of the recommendations, but that they also had to be implemented in a way that was feasible and could maximize the likelihood of adherence to the recommendations in a long-lasting way, not just as a function of a specific intervention. We also simultaneously engaged in several conversations with the Seattle Cancer Care Alliance to define the scope of work and to secure funding. And the Cancer Care Alliance agreed to fund this activity, which started in July of 2013. Brief overview of our Choosing Wisely project. This is a 24-month pilot project to implement these recommendations in the SCCA affiliated network oncology clinics. And the idea here is more than just to implement these. We hope that we will develop a process by which other cost-saving and quality-improving interventions can be rolled out over time. The process we use is we asked the regional providers that were part of the network to prioritize among the Choosing Wisely recommendations. And we focused on getting 1 to 3 recommendations as focus for our implementation strategy. And then again, because this is based and focused on the community providers and their ability and interests, we also are designing now a collaborative strategy for the implementation of those programs. And I'll talk about that towards the end of my presentation. As part of this, we're going to monitor the impact of implementation on costs to patients and to the system, and also on outcomes for patients. We started this program with a stakeholder prioritization survey. Again, our stakeholders are the community oncology clinics that are part of the SCCA network. And those that expressed interest in participating were enrolled in our project as participants. We asked them through a survey to collect their initial responses to the following issues. How important the 5 Choosing Wisely recommendations were for improving value in care, the potential impact of each of the recommendations if they were adopted, the urgency of need to address the recommendations, and finally and importantly, the feasibility of implementing a project to address that specific recommendation. In other words, to make the changes in practice that would be necessary to have that particular recommendation adopted. We sent this out to 15 individuals by web or by email and asked them to complete it on a web survey. 8 people responded, representing the clinics that are listed here on this slide. This slide gives a list of the overall ranking for the 5 ASCO ABIM Choosing Wisely recommendations. You'll notice that colony stimulating factor prescribing was ranked number one almost across the board on all of these domains that we used for evaluating the importance, impact, urgency, and feasibility of the project. We then discussed the results of the survey with the participants, and not only those who completed the survey, but all of the participants in the network. We discussed feasibility of possible interventions and gave a range of possibilities. Then we asked the sites again to re-rank the recommendations following that call. And after that process, two recommendations clearly rose as the top rank. The first one was to, again, not use colony stimulating factors for primary prevention of febrile neutropenia for patients who have a chemotherapy risk of febrile neutropenia of less than 20%. The second choosing wisely strategy was do not perform surveillance testing or imaging for asymptomatic individuals who've been treated for breast cancer with curative intent. Again, these were the two that the network clinic directors and associated staff felt were important, feasible, most urgent, and most doable. So we then moved on to the implementation of those recommendations. And we had to have several discussions about the feasibility of possible interventions. And these were the general questions we asked the clinic directors to address. Can we change behavior, both on the physician or provider side or on the patient side, in a way that would be actionable? What are the likely costs of implementing the interventions? We realize that these clinics are very busy. They don't have a structure necessarily that's designed for research. And this has to be, anything that's done in the system has to be done in a way that is really a minimal burden for the clinics. What's the potential for changing outcomes? Is an intervention likely to change provider or patient behavior in a way that gets closer to the recommendations? And then finally, is it replicable around the network? Can this be applied in all the settings in the network after the experiment is over? We discussed a range of possible interventions, and this is a partial list of the interventions that we covered. One was just information and education, certainly providing the clinics and the providers in those clinics with information about their adherence to choosing wisely, and also how they compare to other providers, both within the SCCA network and elsewhere, was very important. For patients, we focused on the idea of whether decision guides about the risks and benefits of adhering to the recommendations would be meaningful to them. We also talked about financial incentives as a way of addressing adherence. And the idea might here, for example, would be bonuses for appropriate use for meeting targets. We also talked about default systems, whether such things such as standing orders or additional steps for exceptional patients could be applied so that at the point of care, these interventions would be seamless. After discussion about those aspects of the intervention, we came up with preliminary approaches to interventions. First one is for the colony stimulating factor prescribing for patients at low risk for febrile neutropenia, the Choosing Wisely recommendation 5. The clinics agreed to a standing order intervention for CSF prescribing, which basically boils down to standing orders that would be based on the chemotherapy risk, that would be implemented by the pharmacists as automated orders that would only be overridden with a direct intervention by the provider. We would base this on NCCN guidelines and available literature that shows the FN risk of the various regimens that are being used. This will be focusing only on 3 cancers, lung, breast, and colorectal cancer. So the objective is of the study is going to be looking at the effect of the intervention versus usual care on prescribing patterns, rates of febrile neutropenia, costs and outcomes. And it will be a pre-post design. To address the recommendation 4, which is not using tumor markers or costly imaging for surveillance after patients have been treated, breast cancer patients have been treated with curative intent. The provider group that are participating with us came up with a two-pronged intervention. This is going to be a little different from the order entry in that we're going to design this as a partial randomized controlled experiment. All clinics that will be receiving an intervention directed at physicians, which you could call academic detailing, where opinion leaders will come and provide information about the evidence regarding the use of tumor markers and surveillance tests, and at regular morning conferences, and then be available to answer questions both at those meetings and through email. So that the physicians can have, all physicians who are participating can have that knowledge. But we're also aware that patients are often the ones who are asking for these tests because they read about it on the internet or they talk to other people. So we believe to address that issue, we also want to have a patient-oriented intervention. And as I said, this is going to be a randomized prospective experiment where in intervention clinics, patients will receive instructional videos that they will be asked to review during their second or third clinic visit, either on a tablet that will be provided to the clinics, which they can watch in the waiting room, or through a link that they can review at home on their home computers. That'll happen twice, first at the start of treatment, and then when the treatment is completed, the patients will be asked again to review the informational video on surveillance imaging and tumor markers. In the control clinics, we'll have usual care with no patient intervention. Recall that all the clinics will get the physician intervention. That's where we're at right now with the Choosing Wisely intervention. We're in the process of designing a protocol and setting up a randomization procedure. The challenges we're facing, and I think it's just worth mentioning this in closing, is that because this is really designed as a community-based experiment, we have several issues that we have to deal with. The first is that as I mentioned, we want to look at baseline adherence for both of these measures, and accessing data in a way that's not burdensome to the individual clinics is challenging. Fortunately, we have resources, as I mentioned, provided by the Cancer Care Alliance to do this, and our own staff will be reviewing the clinic records, either the electronic records or paper records, as appropriate to get baseline rates. But then, of course, we'll have to track that over those rates over time in a way that is not burdensome on the clinics. So that just getting access to that data in a very heterogeneous network of clinics is challenging. The issue of randomization has come up as a challenge. As you might expect, clinics don't necessarily want to be randomized to a control group. They all would like to be involved in an intervention that they view as desirable. But of course, from the research side, we need to understand whether these interventions are actually effective so that we can compare them with other interventions that will be designed to address these Choosing Wisely initiatives. So that's how we've worked out the compromises that we have and the design that we have. Finally, there's a question about whether this implementation program is actually quality improvement versus true research. And to be honest, we're sort of in a hybrid phase here. A quality improvement program has different regulations and requirements for IRB versus a research program. And we're still talking with our attorneys and our IRB about sorting that out. We think this will be designed as a quality improvement program, but we have a few more issues to address. So that's a high-level overview of where we are with our implementation program for the ASCO ABIM Choosing Wisely program. As I said, this is really a program that's designed by the clinics themselves. We're trying to keep a very low profile and be simply facilitators and let the clinics tell us about the prioritization and about how they could implement these interventions into their practice in a way that's feasible for them and hopefully achieves the outcomes that we all desire. Thank you.
Thank you. I'm delighted to be here today and happy to talk with any of you who want to hear some more about what we're doing, and I believe our information is also in your packets if you'd like to talk more with me after today. So I'm going to talk quickly about what we've been doing, and I just want to start by saying this work has all been funded by the Group Health Foundation, and that's a really important piece of how we've been able to do this so quickly. So how did we get here? This has been a very rapid journey from idea to grant to the initiation of project. Started with in under a 2-month period. We started just under a year ago, and we have done a lot. We are doing this, as Scott just sort of talked about. There are the issues between quality improvement and human subjects research. We are doing this as quality improvement, which has been incredibly important for being able to provide us the ability to rapidly change direction and to be able to address and test new ideas that have come up over the past 11 months. Without the operational and research and data expertise, none of this could have happened, at least not as quickly as we have been doing this work. So I just wanted to talk about that because we were asked to talk about how we actually got here. So Matt Hanley and I have been leading this effort. He couldn't be here today, but he represents the Group Health Delivery System, and I represent the Group Health Research Institute. We have expertise in measurement and analytics, data management knowledge, and we've also been working with what we call our EAGLES group, which is our Enhanced Arts, Graphics, and Literacy and Editorial group, which is helping us try to standardize things, provide information to providers and patients in a standardized way and with a consistent message as well. We've also had very important leadership, and this speaks to David's point about having leadership from the head on up, and that's what we have also had, and there's been a lot of support for the work that we've been doing. So what we've been doing with the measurement selection for Choosing Wisely is that we started out with a list, and this started out about 18 months ago. When the first list came out, we started looking at the feasibility for measurement. We also started looking to see what other types of comparable data might be out there for benchmark data. Some of these are available through Kaiser, and some HEDIS measures, and actually NCQA is in the process of developing and testing overuse measures, several of which are Choosing Wisely measures. We have spent a lot of time with a whiteboard talking through different types of measures, what we could measure, how we could measure it, and how we could operationalize it. And that's one of the things that I think hasn't been described. Scott didn't really touch on it, is that you have a bunch of measures that are outlined as to what not to do, but you don't have any information on how to actually assess what's appropriate, what's not appropriate, and there is a lot of work going on across the country with all sorts of different Choosing Wisely measures. We just had a call last week getting everybody together that we knew about that we're working on measures of Choosing Wisely, and I think it's really important to say that just one measure, developing and operationalizing that and doing measurement on it can be a multi-month process or a year-long process easily just for one measure, not to mention the 165 others that there are to be developing. So we started with things that were not going to be controversial, and I think that was really important because one of the really key components of this was to get buy-in from the physicians so that they understood what we were doing, how we were measuring it, and that there wasn't going to be controversy about what type of feedback they were getting. So although you've heard about the prostate cancer screening and the cervical cancer screening twice already today, I'm going to walk you through what we've done. We are already measuring, and I can't remember who asked the question, it was over here, asked the question about underuse of important services. We already capture those types of quality measures through HEDIS and through our quality reporting measures through Puget Sound Health Alliance. What we don't capture is the overuse of services that are still considered good, and a lot of these Choosing Wisely measures in the area of cancer screening specifically speak to overuse of things that are still considered good. So, PSA screening is not, over the age of 75 is not considered a good measure, but also in cervical cancer screening, measuring or doing Pap screening too frequently is also a concern that exists. And so those are the two measures that we started with that lacked controversy and had operational capacity within the existing data that we have. I'm going to talk about 4 different interventions that we have done. The first one is on these 2 measures. We have provided clinic and provider-specific information on the distribution of overuse of these measures. And as part of that, rather than just disseminating yet another variability measure that shows that there is variability, even with an integrated delivery system, what we decided to do was also provide tools that supported the recommendations for not doing these things as much. So you can see these at the bottom. Develop smart phrases to disseminate along with the information that were designed to talk with patients about why these tests are not recommended. And Matt also generated podcasts that were available for providers around the recommendations, and those are 2 tools that have not generally been disseminated with these types of feedback materials before. We also provided very standard information on what the guidelines are and why we were concerned about overuse, how and what we were measuring so that providers had a sense of that, and then what kind of a difference it does to reduce overuse for these specific measures. And particularly, we included the specific harms and also the downstream costs of tests. And that was something that we learned from providers, was something that they really did not have access to in any other place. So I'm just going to orient you to 2 examples. This is a clinic-specific graph that we have developed. One of the things that we decided that we needed to really be transparent on was how many people actually had the opportunity to be measured on. So you can imagine in the case of if you only have 1 woman that you're seeing for Pap screening, you can either have 100% success or 0% success because you only have 1 person. So the way that we have adopted these graphs, and I'll point to over here, is providing the overall raw number of people that are at risk for being overscreened, and then the proportion of people that are overscreened. And this is not screening over the age of 65, which was one of the measures that we talked about before, but this is actually talking about people that are coming in too frequently, and we had to define what we meant by that. So each of these tick bars represents a different provider in a specific clinic, and to speak to something that was described earlier, everybody's name was actually attached to this so that within a clinic you knew where you stood relative to everyone else, and you also knew whether or not you had a lot more PAPs than anyone else that were contributing to these measures, to give some sort of sense of how stable these measures were. And I think this is a really important improvement on how we provided variability information, because we've been taking into account the actual number of PAPs. So this is an example, and then at the bottom it provides information for the providers as to what we're actually measuring and why, and this is just one graph within the handout that they're getting. This is another example of the proportion of a panel where people over the age of 75 had a PSA test, and you can see that this provider here probably has some work to do, as does this one, in the sense that they have a lot of people, and not only that, they have a very high proportion of people that they're testing over the age of 75 relative to other people. So this is graphically how these data are going out both to the chiefs in each region and also to every provider within each clinic, so that there is transparency at the clinic level on these two rates, two measures of overuse, and these are just the first examples. Yes. That's correct. So, yes, I'm going to repeat the question. So the task force, USPSTF no longer recommends PSA screening for anyone. It's a D recommendation. Are we going to incorporate those into this measure? At this point, we've started with this. I think as we were in the process of this, the task force recommendations came out. We were aligned with the Choosing Wisely measure as well at that point in time. But this, I think there's less controversy about. There is definitely controversy around whether or not men should be screened, regardless of what the task force indicates and what our guidelines say. So we wanted to start with some lower hanging fruit, but yes, I would imagine that that would be something we would be adding to over the course of our work that we're doing. So one of the things that we did, and I think that this is also a really important element of what we've done, is that we've engaged the frontline providers. We had done focus groups at a couple of our clinics after they got their first report on resource stewardship, and we said, what kind of tools did you need? What did you think was useful about this? Were you surprised by any of these things? Did you have any questions? And it was very interesting at that point in time. It looked like it was working. The reports back to the providers were working. Here are some quotes. Having information on the cost of my panel made me start to think about the costs in different ways. Some of them said, it's very helpful to understand that there's variation and that I know where I am, but without more detailed information, I really can't do anything more to improve my practice. So there were definitely a variety of feelings about the reports that came out, but the focus groups were really helpful to understand what additional pieces of information needed to the providers. They really want, and somebody already spoke to this, up-to-date information on outcomes, not process, actionable information, and clear guidelines for excellence, and really appreciated understanding, and this is, I think, particularly relevant for the Choosing Wisely work, is why one particular test is not recommended is not really the issue around that test. It's all the downstream effects of that test and the harms of that particular test. And actually seeing information about that was really helpful for them to be able to articulate conversations with their patients. They also had been very clear that they want more information on how to say no and have challenging conversations. Group Health is in the process of developing a CME specifically related to this topic, so I would stay tuned for that. And by that, this topic, I don't mean choosing wisely, I mean about having hard conversations with patients. And I'm certainly going to take back the suggestion around how to have hard conversations with your colleagues, because that is definitely an area that came up in our focus groups with providers, is that engaging in challenging conversations with providers is something that takes time, and there's a lot of concern over that. Intervention number 2, I'm just going to briefly talk about this. This is super cool. It's a trigger tool that we've developed. It draws on the work that we've been doing in the PAP. This would be very easy if you have electronic medical records. Basically, we're getting real-time data within the course of a week. And Matt is getting emails twice a week on every woman under the age of 21 and over the age of 65, and people that have had PAPs that are too frequent, and any PSA over the age of 75 and a man. He reviews the chart specifically for the people that he gets in the trigger tool, and then he sends an actionable email to the provider with the patient information, the date of the encounter, what happened to both the provider and the chief. Along with that, information on our guidelines and the clinical pearls and the smart phrases around why we are not recommending this. So this is in response to providers asking for actionable information in a timely way that they can actually tie back to a particular patient and encounter. And we really hope we think that this is really, really cool. Haven't heard of anybody else doing this, and we're really excited about it.
Now, does this go out to the provider after the contact with the patient and the test is done, or before?
So once, let's say you've done a PAP and you send it off to the lab, it's done. You can't take that back. So These are orders that have come in, and Matt then gets an email because this test has been done, and it was done probably two days before. He gets the email, then starts the cascade of the trigger. And we're hoping to automate this and to build additional tests. And the idea really is to start increasing awareness and also not just for the provider, but the chiefs as well, so that they're aware that this is going on. And there may very well be situations where it's appropriate to be done. So for example, just to say here, we stopped the trigger test for women over the age of 65 because in the chart review that he was doing to review whether or not they were appropriate, too many of them were appropriate for symptoms that you just couldn't assess from the trigger tool. So we took it off a trigger tool. So that's where we are with trigger tool. I know I'm really quickly. Two more interventions. One is that we have signed our agreement with Consumer Reports. We are providing patient education materials through My Group Health. At this time, over the past quarter, we've had 507 hits to the homepage, 5 hits specifically to the Choosing Wisely link. Any organization that signs an agreement with Consumer Reports, they will set up a microsite for your organization that provides all of and updates all of the information, so it is very minimal for you and your organization to provide this information. So this is new. It's up through our patient portal, and by an agreement with them, all that means is that we cannot change the branding or anything like that. We have not entered into any type of a relationship that is at all concerning for an organization, but I can say more about that if anybody asks. Number 4, we just started this on October 1st. We are piloting the patient-centered materials for low back pain, imaging for headache, antibiotic for sinus symptoms, and antibiotic for pediatric URIs. We are handing them out at urgent care, and we are doing this in a controlled trial fashion in that we are only using 2 of our urgent cares as test sites. All of the other are control sites. This is going to go on for a month. It is not a statistically powered intervention that is scientifically oriented. It is we are looking at the patient and provider satisfaction and interest in this. So that's going on right now. So with that, you have all the rest of these slides. These are our other areas of focus. We are certainly looking for additional collaborators that are looking to test materials and other types of things. We're quite interested in the idea of a PCORI application where we would be able to partner with other community folks to test these materials and to engage patients and providers. So with that, I thank you and look forward to questions later.
Thank you.
Thanks, everybody. I'm Scott Kronlund. This is Francis Mercado. I'm going to give him the mic in a minute here. I want to talk a little bit about what we've been doing. Pete, you mentioned in your talk about getting ready for accountable care. So we down in Pierce County decided, what the heck? Well, let's not just get ready. Let's just do it.
Let's do it.
So we're actually building the airplane as it's flying. There was a great commercial about that in the Super Bowl about 5 or 6 years ago, and that's kind of what it feels like. But we are here representing the Franciscan Northwest Physician Health Network, aka Rainier Health Network. We are one of 2 CMS-approved ACOs in the state of Washington, and we are just 6 months behind our good friend Dr. Kronlund and the Polyclinic in this venture. And so we always pick his brains about what new Medicare nightmare he's already had to deal with. But this is a joint venture between the Franciscan system, including the medical group, the hospitals, and Northwest Physician Network, and we are in the Medicare Shared Savings Program. We have been attributed about 28,000 patients with a total annual spend of about $212 million, and our job is to save 2.5%. And so we applied last September. On January 10th, we found out that we went live on January 1st. Oh, by the way. And we got our first patient-level data in July. So this is really building it as we go. But knowing that we had to go out and try to hit the savings targets right out of the gate, we think, we actually formed a quality committee that Francis and I have the privilege of co-chairing. And it's a big ecumenical group of folks. We've got, ACO leadership, we've got physician leaders from all of from the systems, from the hospital, from the outpatient world, ER, hospice. We've got a pharmacist. We just added the new VP for the hospitalist team. And we have all of our nursing care managers. And basically, our initial agenda has really been, where can we get the low-hanging fruit? Where can we move into, evidence-based practice? So we've been working to get, for example, sifting through the top 5% of our patients who consume 31% of the dollars.
And what was very, very much apparent was choosing wisely really matched up with what we were trying to do.
Right.
We always strived for the triple aim. We thought about overutilization. We liked that it was evidence-based, and it really aligned with our ACO principles.
Yeah, and really because in the shared savings model, not only do you have to hit the savings target, but you also have to, fulfill patient experience benchmarks and other clinical quality benchmarks that, by the way, have not yet been finalized by the feds. Other than the list, we don't know what the thresholds are, but nonetheless, we're still flying our plane. So go ahead.
So, right off the bat, we knew, and at the time when we did our work group, there were 140 recommendations. We already knew that was too much. If you don't know Franciscan, we are, very much into, the fee-for-service world, and this is our one of our first journeys into a more risk modeled approach. And NPN is very similar in culture, and we wanted to break it to them very gently. And so we realized that we wanted to limit the number. We wanted to decrease the repeats. If you went through back then 140 and now 300, there are several repeats. And we wanted to capture a wide audience and have very relevant recommendations or suggestions to our constituents. So we wanted to focus primarily on primary care. And as we convened the Choosing Wisely, the hospitalist director said, I want all of our hospitalist recommendations there too. So he said, okay.
Right.
And we added the hospitalist recommendations. So we came up with 30 recommendations, and Scott and I decided that we should classify them to make it a little bit more palatable. So and if you look at your slides, these are the classifications that we did. Imaging has 4 recommendations. Common infections, which has the acute sinusitis and the CAT scan recommendation. Preventative health, and so these were the recommendations that we really wanted to focus on to begin with. Now, I've noticed that the others have already taken the next step in monitoring them. Right now, we do not have the infrastructure of monitoring these recommendations, but as David, shoot, mentioned, that there is that group in Cedars-Sinai that's already doing the work of trying to monitor this in the EPIC environment, and I'm glad that Group Health is doing that as well. Maybe we should collaborate.
We should.
Yeah.
Sign us up.
So, and once you go into the work group level and really talk to everybody involved, we had an independent physician who was really passionate about non-culprit lesions. You remember that? Right. Yeah. And he really wanted it there. He wanted to make sure that, we don't want stenting in non-culprit, which is one of the recommendations. And, we vetted it back and forth. We decided not to add it there. Number one, probably for fear of retaliation from our cardiologists, number one. And the second one was we wanted to make it a little bit more palatable.
Right.
So these are the hospital recommendations that we added to. So our next steps was really just to spread the word. Mm-hmm. You want to?
Yeah, I think one of the things when we chose these, a couple other criteria too, we obviously wanted things that were germane to Medicare population, so hopefully early induction of labor is not one of those things.
Yeah.
But also something that would span the continuum, because one of the things that, I'm sure many of you have experienced the fact that healthcare is often delivered in silos. No big surprise. And in our efforts to try to span the continuum and start to create a more integrated approach, we also wanted to have guidelines that would engage people at the primary care level, at the ambulatory level, in the hospital level, and because of a long-standing history and heritage of palliative care and hospice at the Franciscans, wanted to make sure that we could include that as well. So we do have a little subgroup of our quality committee that's been working on this. I think, too, in terms of this critical conversations is what we chose to call it here in the slide, but really excited to know that those videos are going to become available. Because I think as a primary care doc, I mean, there's always this time pressure and whatnot, but I think there are some tricks that you can learn, that our physicians can learn along the way and other providers to have this conversation, because you can always do the MRI. I hurt my back about 3 months ago. I had excruciating pain down my left leg for about 3 days. I sat in a chair and I wiggled in the chair and my leg pain went away. I don't know whether or not I should have an MRI or not, but 3 months later I haven't had one. Because again, what's a red flag? And can we use that as a way of teaching our patients? Because we can always do the MRI should any of the following things, occur and that sort of thing. And
It's just that clinical
Right.
decision support element that's really crucial.
So it is important how you can weave this into your decision-making and conversation. Our ACO newsletter, we're about to launch a newsletter for all of our providers. And one of the things I wanted to highlight in there, because it was in one of Pete's slides, it went by real fast, was the Clinical Performance Improvement Network, otherwise known as CPIN. There you go. It is a joint venture of the WSMA, what is our Foundation for Quality, the Alliance, is it WAFP part of that thing too? Yeah, exactly. But it's a lunch and learn, it's a webinar. It's a brown bag webinar from 12:15 to 1:15. We have about a month. We'll get get them out. And then 2014, the steering committee, all of us on that committee have decided that we're going to feature choosing wisely as the focus for all of those webinars going forward. So we're going to get that out in our publications. And we've got a little team of marketing people and whatnot too that are putting together these key messages so that we can get this e-newsletter out on a regular basis.
And because of CMS regulations, we're not broadcasting this to our patients right away. It's going to be for our providers. CMS regulations, we're supposed to, any information we bring out to our patients, we have to vet it through them. But internal communications, we can certainly just communicate to our providers. So that would be the first step. We'll also be doing grand rounds later this month about choosing wisely, just starting the conversation and feeling what the provider group and nurses and care managers feel about choosing wisely, and just eliciting some reaction from them. And because, I'm not sure how well you guys know your constituents, but I thought that this would be a good way to see where they are and how to proceed.
Yep, and then finally, we've got lots of ideas from all of you too. But Francis, you've been to the EPIC.
Yeah, so I went to the EPIC user group. We got a lot
and-
of ideas from that Cedars-Sinai group, and it's amazing. Right now with our 2012 EPIC implementation, you already have some best practice advisories which tell you what you should do, but it didn't have any alerts that you ordered an antibiotic for your sinusitis, or you ordered a CAT scan for your sinusitis. It doesn't have those stops, even soft stops right now. And in the future state, you should be able to build that in. And it's interesting what Group Health's already done.
Right.
And future state, theoretically, you should be able to build that into your
Right, and we
EMR.
want to get that consumer reports piece in place. Hopefully CMS won't have any big problems with that. They're pretty fussy about some of these things. And then ultimately too, so we can have those things available at the point of care to help guide these conversations. So we're very much in a shoe leather approach at this point in time, but at least we got our foot in the door and we got some things moving.